And down the back, could you take your seats, please? We'll try and get the show on the road. Now, there's a little bit of technology involved in today's session, so hopefully those who aren't yet in the room will be able to work it out on the go. We do have a quorum, so we can get underway. It's very good to see when particular groups of delegates manage to get here on time, and I note the doctors in training have done particularly well. So today, what we're going to do is debate a series of policy resolutions that have come forward to you as the delegates at National Conference from the committees and councils of Federal Council and from some of the state councils. And we have structured today in this way largely as a response to delegates in previous years who have felt that there is not enough opportunity for members to participate in debates on quite important issues of policy. So today is a little bit of a pilot. If it goes well, if you enjoy it, if it's not too challenging for us to manage as a process, then it may well become a regular feature of AMA conferences in the future. It is the way British and American colleagues run their conferences, and it's very much democracy in action. Part of the reason we changed our standing orders yesterday was to enable all members who come to National Conference to participate in the debates, both to speak and to vote, and that too broadens the appeal of attendance at National Conference. So you will have all been given a little device when you came in, and I'll say this annoyingly throughout the day. You need to leave those devices in the room. They cost money. We have to pay for any that disappear, so please leave them behind. Now, under the standing orders, there are some rules around today's debates that you need to pay attention to. We have quite a lot of motions before you. We would like to try and get through as many of them as we can during the day, while still allowing the capacity for the delegate briefing sessions from candidates to be slotted in. Under the rules of debate that were adopted yesterday in the standing orders, there is a maximum of 30 minutes for any one of the motions. Now, on Bev's arithmetic, that's a maximum of about 7 people to use the 30 minutes, given that the mover of the motion can have up to 5 minutes to speak to his or her motion. The mover of the motion also has a right of reply at the end of no more than 3 minutes. All other speakers are limited to 3 minutes, and we will be timing you, and we will guillotine at the 30 minutes because it just will not be possible to get through the material that we have otherwise. We won't take amendments or any of those other nice things that you can do in debate, and we won't use the normal rules of debate of a speaker in favour and a speaker against. We will take speakers as they come to the microphones. There are 4 numbered microphones in the room, and that the numbering is to assist Bev and I to identify speakers. Could I ask that those who are moving motions come first to microphone 1, and that is because that is where our camera will start, and that's to assist with the live streaming of debates which people are watching at home. So start with camera 1 for the movers. Now, just in terms of the standing of these motions, when they are adopted by delegates, they're not yet binding on the AMA, but what is required then is for those motions that have support of delegates to go forward to Federal Council for further review and adoption. And you'll recall yesterday when we provided a report on matters arising from last year's urgency motions, you will see that Federal Council did deal with those matters at Federal Council meetings subsequent to conference. So the same will happen with all of today's resolutions that are passed by delegates. It obviously is going to take a little while for them to work their way through Federal Council, but they will all be dealt with over the next 12 months. So let's have a little test of your devices. Does everyone have a keypad? So everyone with either a dark blue or a light blue lanyard should have a keypad. Is there anyone who doesn't have a keypad? Could you wake your keypad up? And you can press any button to wake it up. No, we don't smack it, we just press a button. And what we are going to do when we vote is vote in favour by pressing 1, against by pressing 2, and abstaining by pressing 3. You don't need to press OK, you just press the number. And if you change your mind, then you can override by selecting the correct number. So if you've voted against and you've changed your mind and want to vote in favour, you simply press the 1, which overrides the 2 that you've already pressed. Now, there'll be some information that will come up on the screens as the voting proceeds. Down in the bottom right-hand corner, you'll see that there is a timer for the number of seconds left to vote. And down in the bottom left-hand corner, you will see a count as votes are registered. So the grey button will show when voting is not open, and the green button will show when voting is open. Now, with some of the longer resolutions, we may leave the voting open even after it has turned grey, simply to allow delegates sufficient time to read the motion and then to do their voting, because we obviously want to have as many delegates voting as possible. Now, we're going to have a little practice run to see that you all understand how to use your devices. This is the first practice motion, that our AMA supports the mandatory introduction of walking buses for school children. So could you please now use your device to vote in favour, against, or to abstain on that matter? You'll see that the green button is showing that it's open and the votes are being registered. And there we have the result, which shows that it's a very evenly split vote. We'll try again with the second one. The motion is that our AMA supports funding for companion pets in aged care facilities. The green light is on. Please exercise your vote. We will have a talk with our vote counter before we get on to the motions. So what we might do while that's being resolved is start into the debates themselves, because it obviously will take a little while for the motions to be debated. The motions will be debated in the order in which they are found in your handbooks. So it's a totally random order. There is no particular priority to these motions. They are simply amongst those that have been submitted and approved by Federal Council. So we will start with the first one, and I'll hand back to the Chair to conduct proceedings.
Thank you. All right, here we go. Topic number 1 for the day, funding general practice to reduce hospitalisation. A motion moved by Dr Richard Kidd and seconded by Dr Sean Rudd and presented by Dr Sean Rudd. Thanks, Sean.
Thank you. I feel very awkward talking to the wall, but I could talk to anything, really. Unfortunately, the plan was not for me to stand up here this morning. I got dobbed in because Richard's not here. But you can all read the draft motion, you can read the bit of writing before it, but what I want to say is the essence of the motion really is about the fact that in general practice we're continually asked to do more and more and funded less and less. So one of the things that the AMA Council of General Practice at the federal level always tries to do is to work out some way where we can get more funding into general practice. And this is really what this is about. But at the end of the day, it's also about patient care, and that's our two most important things. So we would like to get more funding into general practice. We think this is a possibility of doing that. It's not perfect, nobody can say that, but that's really what it's about, is getting more funding into general practice. That's the essence of it, and getting better patient care so people aren't bouncing in and out of hospital. So I commend the motion to you.
Thank you, Dr Rudd. Any speakers to the motion?
Oh, any speakers?
Okay. Thank you.
Yep.
Microphone 2. Please identify yourself when you stand.
Paul Neskins, GP, Hervey Bay, ex-colleague of Dr Rudd. Look, I support the notion of keeping people out of hospital. I just want to make the point that I think it's a bit sad that we have to start saying things about GPs keeping things out of hospital. When I was a young doctor, it was, that's normal, that's just part of doing our job. So, not that I'm essentially for or against the motion, but I think we have to be a bit careful about trying to make things that are just what normal business and core business fit in with what hospitals are talking about with this sexy hospital avoidance stuff. It's core business for all GPs, it's core business for doctors to keep our patients well, living well, and it's just a shame, I think, that we have to have formal motions about something as basic as avoiding hospitals. Thank you.
Thank you. Microphone 1.
Brad Frankham, AMA New South Wales. So 2 issues here, I think. One is, does cost shifting actually provide the solution to general practice funding? Because that's what this suggests. We all agree that general practice needs more money, but getting state governments to pay through the funding of LHDs rather than the federal government, who has the bigger purse, funding general practice properly, doesn't seem to be the way to go to me. So I'd like the Speaker to perhaps comment on that. And second issue, I guess, is whether some of that investment should be in information technology, so that, in fact, if you want better integration of care between the sectors, you just need better digital platforms to allow that to occur.
Thank you. Microphone 2.
Simon Torvaldson, GP from WA. I guess the thing is that it's not about what we're doing, that we're doing anything different from what we did years ago. It's really about how we best fund things. I mean, I hear what Brad says about, well, shouldn't we be pushing the Commonwealth, but we're doing that as well. So this is, I think, about how we can do something additional. But my point is that if we're going to do that, maybe we should also look at actually what that funding is achieving. And I noticed that in the motion it talks about GP-led care, and one of the things that I think that we should be looking at is funding the allied health and other services that will support us in doing things better in general practice and providing some of the supports for our patients that currently don't exist. So why should I be sending my patient to the hospital outpatient clinic to see the podiatrist or even to see a specialist? Why can't they come and work with me? Why can't we get funding for allied health? So I think that if we play our cards right, there might be a mechanism where we can attract more funding into general practice and perhaps to do things that previously we didn't do. So I think the devil will be in the detail and actually how we push this policy through. But I think that any policy that improves funding for general practice at least deserves to be looked at and worked up.
Thank you. Microphone 1.
Andrew Pesher, New South Wales. I'm also a member of a local health district board. I would strongly support the intent of the motion. It's obviously fairly broad, and I support it because it's just an opening. We talk about integrated care a lot, but there's no mechanism to integrate care. If we start with saying that hospital funding should be diverted to preventive care in primary care, it opens the discussion of how that will happen, and the other 3 responders have already alluded to a whole lot of things which could be used. So I support the motion. It's only an opening, but it would be a great principle to support because it then makes people think, well, how are we going to do that? And that's the really important discussion.
Thank you. Microphone 1.
I'm Kathy Hutton. I'm a GP from Victoria, but I'm also on the board of Western Health, which is a large hospital in the west of Melbourne. We have a program there called Health Links, which is exactly about this, and it's about supporting the most complex and most needy patients so as to keep them at home as much as possible and avoid hospital admissions. One of the measures that we have on this program is days at home, because a lot of these patients were just in and out of the hospital all the time. The GPs don't have to change much what they're doing. They keep doing the work they're doing, and we do it well. What is needed is more coordination for these patients so that the patients can understand where they get their care from, when to present and how to present, and just make the system a lot easier for these very needy, complex patients. And it does work to keep them out of hospital.
Thank you. If there are no more speakers, Dr. Sean Rudd, right of reply.
Well, I think I should reply to Brad's question about the funding. I suppose the simple answer is I don't care where the money comes from.
All right, well that concludes the debate, and I'm hoping we're ready to vote.
Let's see what happens, I guess.
Well, won't it come up on the screen?
We need to put the motion.
Okay, so the motion that we're going to put is that our AMA develops policy that encourages local hospital networks to fund targeted GP-led primary health care services designed to reduce preventable hospital admissions and readmissions. Voting is open. Who's our voting returning officer? Have we got one up the back?
Just wait for it to come up.
It's refreshing itself.
Okay, voting. Watch that spot. Voting is open. It's not. So the motion is carried. Thank you. The next topic, booking fees. And this motion is moved by Dr. Brad Horsburgh, seconded by Associate Professor Julian Raitt. Dr. Horsburgh, can you come to microphone 1, please?
Thank you, Madam Chair. This motion, I think, is rather prescient because it will feature, along with other anomalies, in the Four Corners report, which will be at 8:30 on Monday night. Booking fees and other billing anomalies are what John Howard would have called a barbecue conversation stopper. They don't, in many cases, pass the smell test, and they are materially damaging our collective reputations. It is true that the statistics show that 89% of in-hospital services for insured patients are with no gap. A further 6% are known with known gap, and that leaves 5% otherwise. But the veracity of these statistics are really unknown, because the last time that booking fees were assayed formally was in 2006, when the incidence of a booking fee was found to be less than 1% and therefore deemed to be insignificant. Anecdotal evidence would suggest that this is possibly not the case anymore. This matters because the private health insurance rebates that patients receive are inextricably linked to the MBS schedule, which has not been indexed adequately for 30 years. Booking fees are doing for our collective reputation what Donald Trump is doing for the United States international relations. I draw you to the 2017 Federal Council position statement, which states that the AMA does not support egregious or outrageous billing. We support that the invoicing of medical services should be in keeping with either the AMA or the MBS fee schedule. And in a situation where a practitioner has a contractual agreement with a private health insurance company, they should maintain good faith with that contract they have thus signed. This will cause considerable pain on Monday night. It will reflect a side of our practice which needs to be questioned, and we should, in the draft motion, as it points out, we should consider a publicity campaign against egregious billing. Booking fees take 3 forms. Numerically, the smallest number of those would be the egregious billing of, say, this is the $30,000 craniotomy. Now, that is what finds its way onto the front of the Sydney Morning Herald. It is very rare, it does occur, and it is embarrassing when it occurs. The second type is where there's a splitting of the fees between 2 practitioners. So in one town in this country, there is a very close relationship between the surgeon and the anaesthetist involved. And in this particular situation, it usually brings into play the extended Medicare safety net. Working around the morass, which is the extended Medicare safety net, they find item numbers where they may charge up to 45 times the MBS fee for the anaesthetic fee and up to 16 times the MBS fee for the surgical fee, so as to transfer the cost to the Medicare safety net. But in most cases, it's simply a booking fee. And the doctors will tell you that they do this because if they have a known gap situation, the patient gets a smaller rebate from their private health insurance than if it's a no gap situation. I would put it to you that this is disingenuous, it is cowardly, and they should be prepared to stand up and say the fee is X, and if you don't like it, go somewhere else, but be honest with the patients, because it is doing our collective reputations no good at all. I recommend the motion.
Thank you. Any speakers to the motion? Thank you. Microphone 2.
Thank you. Fred Beatros from New South Wales. I'm a general surgeon in New South Wales, and I strongly support the motion. This undoubtedly has an impact on all of us as practitioners. If you think it's a hospital-based issue, it's not. It will affect us right down the line in primary care, and the bed that we make now is the bed that we will be sleeping in for the next 30 years. It extends from doctors in training to medical students. I think with the freeze that we have on the Medicare schedule at present, the impact I accept with the motion is that this may have driven some of the billing practices, but I agree that we as the AMA need to be strong on this. We need to be vocal and we need to show leadership across the medical profession on it. I strongly support the motion, and I'd welcome any other speakers to support it as well.
Thank you. Microphone 1.
Just starting to get used to life after the presidency. Michael Gannon, obstetrician from Perth. I strongly support the motion. It is absolutely essential that in our advocacy on this topic we do not get confused the issue of the billing of the planning and management fee by specialist and GP obstetricians for management of pregnancy. That is entirely different to this often unlawful, immoral and egregious behaviour. We can't get that issue confused in it.
Thank you. Microphone 1.
Andrew Pesha, also an obstetrician, and a lot of sort of corporate memory about extended Medicare safety net. And when it was introduced, the possibility of this discussion happening was pretty obvious down the track. I think a couple of things. Extended Medicare safety net, when it was introduced by Tony Abbott, was meant to apply to general practice. It was there as one of a number of proposals to support general practice, to allow GPs to charge what they needed to charge and have government subsidy for that above and beyond the MBS item number rebate. And as that, I don't think anyone would disagree with that intent. Unfortunately, when it was announced, they forgot to say this is for GPs, even though it was announced with a whole raft of GP item enhancements. And I, as an obstetrician and involved in medical politics, then sort of rang up the department saying, can you just clarify that this is really meant for GPs and it's not for my obstetric colleagues to start charging $4,000 gaps, which is going to be underpinned by the Medicare safety net? And they said, oh, we didn't think of that. Amazing, they didn't think of that. We'll check with the minister. They checked with the minister and the reply was, it's okay, you can charge it in obstetrics. And I said, well, don't come back to me in 6 months' time telling me how outrageous it is that obstetricians are charging, because there's these out-of-pockets they're now charging and they're going to charge them to Medicare safety net. So the Medicare safety net is a very important part of this discussion and I'm glad it's been raised. I would also say that there has to be some acceptance by the profession of a reasonable charge for services. It's a difficult discussion, but I think it's one that has to be made in the context of fully informed financial consent, and especially in situations where patients under duress, they've got an illness, they don't have 3 months to shop around and find the right price. You know, I think we do have a responsibility to think about that. So that's my contribution. I would support the motion.
Thank you. Microphone 2.
Hello, I'm Antonio Didio, GP from the ACT. I strongly support the motion as well. I hope nobody here ever appears before the PSR, but I've had a couple of cases appear this year for the egregious and inappropriate use of some item numbers which did not have a cap on their safety net. But more importantly, particularly for the doctors in training, if you ever see one of my patients and you plan on outrageously overbilling them, you must first check whether or not they are the producer of an important current affairs show. Trap for young players.
Thank you. Microphone 1.
Ross Kerridge, Newcastle in New South Wales. I'd like to support the motion. I would caution that we do need to come to terms with the fact that some of our, not necessarily some of our members, some doctors are engaging in behaviour that does no good for anyone, certainly does no good for the reputation of the medical profession, and we're going to have to call them out. And you mentioned $30,000 craniotomies. Sorry, that's, yeah, we're talking 100,000. I'm told you go to the GoFundMe page, which I'm not that tech savvy, but a whole percentage of them apparently are associated with people having GoFundMe campaigns to raise money for their friend, their relative, whatever, to get surgery, and they are emotionally blackmailed into buying it, and it's outrageous behaviour, and we need to start calling these people out. And we know who at least one of them is.
Thank you. Microphone 2.
Steve Hambleton, GP from Brisbane. Look, I totally support this motion as well, and we've heard about informed financial consent. We've also heard about the unequal power our patients have when they're ill. And frankly, when they're faced with a decision to proceed with a investigation or an operation, they're not in a position to actually shop around. They're not in a position to actually test prices. And I think the broader argument is about transparency and fees, and actually allowing we GPs to actually advocate for our patients and help them select the appropriate professional person. At the moment, the GP is the least likely person to know what the cost is going to be. Now, the booking fees are one of the issues that makes it very difficult for us to track that. If we can get rid of that and we can have a better fee transparency, we can actually be advocates for our patients and we can refer to our colleagues. It's about knowing what the cost is going to be before the event, and I think that's really important. You know, we know the rebates don't match what it costs to deliver quality care. We just need to know what the numbers are. So I support the motion.
Thank you. And microphone 1.
Thank you. Gino Pecoraro to complete the triumvirate, another obstetrician from Queensland. I think the central, I'm speaking in favour of the motion. The central part is that the schedule fees that are set by Medicare and which are used by health funds to decide what they're going to pay are not indexed to anything. And so I think this all goes back to if we can get them to adopt a realistic schedule of fees, I would argue the AMA schedule of fees, which is indexed, a lot of this should go away, because then we can say if you charge more than the AMA fee, then you're egregiously charging. Because egregious charging, sure, the $100,000 craniotomy is no question, but there are egregious means different things to different people. So, thank you.
Thank you. That concludes the debate. The draft motion is in a number of parts, and we'll ask you to vote on the parts separately. The motion is that our AMA considers the reputational impact that booking fees and split bills have on the wider medical profession. Voting is open. Okay, thank you. Part 1 of the motion is carried. The next piece, that our AMA considers a campaign to publicly denounce inappropriate billing practices and, in particular, booking fees. Voting is open. And that part of the draft motion is carried. Next, that our AMA endorses appropriate billing practices to be where medical services are linked to itemised fee schedules, such as the MBS or AMA fees list. Voting is open.
Can we endorse the MBS? Great idea. We can't endorse that.
Just for the benefit, these are advisory motions only, so if they go forward to Federal Council, I can assure you they will be thrashed out within an inch of their lives. So we won't be changing the motions on the floor today. Okay, and that part of the motion is carried. The next two parts of the motion are noting motions. I don't think we need to vote for them. Is that all right with the returning officer? Can we move on? So we note that the RACS has previously written to the AMA in 2017 seeking the AMA's support in making a more explicit statement on fee splitting, and we note the revised 2017 AMA position statement on setting medical fees and billing practices. Very good, thank you. We'll now go to our next topic. Should we be quarantining training places for rural medical generalists? Moved by Georgina Taylor, seconded by Peter Maguire. Thank you.
For those who don't know me, I'm the Northern Territory representative on the Council of Doctors in Training at the moment, and I'm a rural GP trainee working in East Arnhem Land in the Northern Territory. I'm very proud that this motion's come through from CDT in support of rural trainees, and also with support from the Council of Rural Doctors. I was also really proud to see general broad support for rural trainee issues at the Workforce Summit held earlier this year. And with the proposal around the National Rural Generalist Training Pathway, I think we have a really excellent opportunity to advocate for specifically what we need to see for rural trainees to improve their training pathway, improve retention in rural areas, and ultimately improve health outcomes for rural areas. Specifically, in speaking to this policy, I know that my own experience in getting the skills areas that we need, particularly in the hospital setting, prior to entering and during GP training is very difficult. We have a system where we have state-funded hospitals and federally funded GP training program with no particular links between the two. And we also have a competitive situation where both GP trainees and non-GP specialist trainees are often competing for similar skills positions in areas such as anaesthetics, obstetrics, paediatrics and so forth. So for me this policy is really about both recognising the needs of our rural GP trainees, but also recognising that this needs to be funded and quarantined separately to existing training places to reduce that competition. So I see the two key elements of this motion as drafted, as noting that these would be additional places, and also noting that these should be funded through the National Rural Generalist Training Pathway. So that should hopefully address a lot of the concerns that we've had previously about such proposing such motions, in that it would create unnecessary competition or division between both specialist trainees and other GP trainees. I think that it's really important that for rural trainees, in order to work in rural areas, we need to be supported to gain the things that we need, partly as minimum standards to complete our training. And to complete our training, we are required to get a number of specific skill areas, but also just to be equipped to properly serve the rural communities in which we work, which does require quite an advanced level of skill set to be comfortable in managing a lot of things much further from tertiary centres, and often managing patients in very remote settings before able to receive further care and transfer to those settings. So I call on National Conference to support this motion to support our rural GP trainees. Thank you.
Thank you. So the draft motion is that our AMA calls on the Commonwealth and state and territory governments to fund sufficient additional training posts required to meet the needs of the NRGP and agrees that these should be quarantined for the NRGP. We'll take speakers. Microphone 2.
Thank you. Peter Maguire, GP from Western Australia, member of the Council of Rural Doctors and seconder of the motion. Just to add the view from the Council of Rural Doctors, we obviously strongly support the motion and very pleased to see the Doctors in Training propose it. We see it as an issue of equity and access and a necessary step to address the poor health outcomes for rural communities and their difficulty in accessing appropriate medical care. Is there a problem at the moment? Yes, we see that there is. For upwards of 30 years now, I think we've struggled to train sufficient graduates with the advanced skills necessary to work in rural Australia, and there has been a huge reliance on international medical graduates coming in who already possess those skills. But we have been struggling now for so long to provide adequate training for rural trainees. This is an opportunity to level the playing field. It's not as if we have a level playing field now. The disadvantage is for rural generalist trainees, and this I think will start to even things up if we can get the rural generalist pathway going. Why now? The National Rural Generalist Pathway is a big opportunity to dramatically increase the number of rural generalists with the right skills. The barriers in the past have largely been, in some jurisdictions anyway, failure of state governments and teaching hospitals to provide the necessary skills training for GP trainees particularly. And we're hoping that the National Rural Generalist Pathway will actually address that. I guess it's important to realise this started off as a discussion 30 years ago about obstetrics and anaesthetics, but the skills that we're talking about include the non-procedural skills such as internal medicine, paediatrics, mental health particularly, and we need improved skills training in those areas for the rural generalists. So the Rural Council commends the motion and asks for the AMA support. Thank you.
Thank you. Microphone 3.
Thank you, Chair. Mark Adds from Ballarat and Dean of the Rural Clinical School, Deakin. I stand to support this motion because it's really the first clear message that I think the AMA is delivering, that in fact we have to reverse the polarity of training. When I say that, we have to stop what is just a constant stream of urban-based practitioners and trainees coming out to rural areas and then disappearing back and saying, thanks, I've had my rural experience. We need to reverse that polarity so we're actually training our future graduates for rural and regional practice in rural and regional centres and ensure that the metropolitan centres provide the appropriate training environment so those skill sets can be gained. This is one step in that direction. I'd like to see it expanded to across not just the GP rural specialists but across the entire college training programs. So I commend the motion.
Thank you. Microphone 2.
Simon Torvaldson. I'm speaking here really as the chair of AMA-WA Council of General Practice because we deal with rural issues quite a lot and certainly in favour of the motion, but also would like to point out that really the training issue is just the beginning, because if we don't have government and health department policies in place to actually utilise these people once they're graduated and utilise them properly and give them the opportunity to keep up their skills, which includes in upskilling in metropolitan areas as well, where necessary, then we're wasting our time. So I would like to, if the motion gets up, those who consider it to actually consider what happens after training and the way in which we can best utilise these practitioners And for example, we have examples in WA at the moment of the health department essentially trying to lock rural generalists out of hospitals and fly in salaried specialists on a fly-in, fly-out basis because they feel that it's easier to control. And for various other misguided reasons, there needs to be a concerted policy push that encompasses the whole of rural generalism, not just the training.
Thank you. Microphone 1.
Patricia Montanaro, past President, South Australia, and a Metropolitan GP. I would like to support and commend this motion, and the reason I'd like to do that is because I think we need to fully support the third of our patients who live in rural and remote Australia, and the AMA needs to be very serious on this particular topic, and it is maybe an area that many of us have not worked in. I've worked in it for only a short time, and I think we need to address the balance. So I would like to commend the motion. I would like to see it debated. I'd like to see all Australians have the access. Thank you.
Thank you. Microphone 3.
Thank you. Sarah Cole, orthopaedic surgeon from Cairns. I'm involved in the Rural Surgeons Committee of the College of Surgeons. We recently had a meeting in Melbourne, and it was felt that the culture around regional practice is the issue. We had a day-long brainstorming session, and the model of the mountain of trainees, such that there is such an enormous number of trainees that eventually some will trickle away to the regional areas, does not appear to be working for the College of Surgeons. It is felt that conferences, meetings that promote metropolitan practitioners as being thought leaders and super specialists is perhaps not conducive to excellent practitioners moving to regional areas, and that perhaps it could be promoted amongst colleges and perhaps the AMA that that there is an opportunity in conferences and conferences for regional specialists to promote the work that they do and the importance of their findings, and more research support for regional practitioners. Thank you.
Thank you. That concludes debate. Oh, sorry, one more. Microphone 3.
Hi, I'm Alison Sorensen. I'm a GP from Western Australia, technically rural, but only just. I'd like to speak. I support the first part of the motion, but I'm conflicted about the second, about quarantining places. My issue is that I think in our system at the moment we don't have the data to tell us. We know in general terms that we don't have enough doctors in rural areas. We don't have the doctors with the skills in those areas. It's a problem in regional Australia, and it's a problem in certain metro areas that we don't have certain specialists. I think we actually need to be advocating about mapping our system better so that we understand what we're short of and where, so that trainees actually have an understanding of if they're starting in training now or pursuing a particular training opportunity, that when they reach the conclusion they have a job opportunity that actually exists, rather than the system what we have at the moment where certain specialty programs are producing far more fellows than there are positions, and there's actually not even a position for them in a rural area because the rural community can't support a full-time specialist or even a part-time specialist. I have issues with quarantining places because I think you split the profession. That's not to undermine the importance of making sure that these rural communities' needs are serviced, but I think we should be looking at it as from a different perspective. What are the rural communities that have particular needs? What are their needs? How do we advertise that to junior doctors so they can start thinking about it very early about that's where I want to live and work and these are the skills that my community needs, rather than it being about I want to be a junior doctor and I want to be a neurosurgeon. It's I am looking at living and working in far north Queensland, and to be the right doctor for that community, these are the skills that I need to have.
Thank you. Microphone 4.
I'm Shanaz Salindra, General Surgeon from Coffs Harbour, involved in our rural surgery section, and I would actually say that we've had extensive debate about quarantine places within the college across specialties, and I'll bring the example of endoscopy. So we know that endoscopy is an essential skill. It's an important skill in all rural areas, so ranging across the board of the different spectrum of what we mean by rural, from non-metropolitan to truly rural. And I think this example really highlights where the college and the group for general practice training have really come together and said, we want to experience and ensure that our trainees have equal experience and the same standards. So the agreement is that whether you're a rural generalist doing endoscopy, whether you're a general surgery trainee or a gastroenterology trainee, that you'll all be required to meet the same standard in having a GESA accredited post, and that you will meet the same logbook requirements, and that all of your patients will have equal care. And I think that's the key point in quarantining those places, is to make sure that rural patients are getting equal quality care from experienced, well-trained professionals in supervised training posts. And the best way that we can ensure those posts are equal and of the same standard is to quarantine those places. So from a general surgery point of view, we strongly supported that movement, and I think that recognises, you know, key procedural skills that are essential, and as well as having pathways to then refer on to support that. So if you are a generalist rural person who's done an endoscopy, you found a colon cancer, how do you actually move on? How do you refer that patient on and ensure they get the right care? So working collaboratively and actually ensuring you have the right skills and of equal standard is really important, and I think that we've done well to get that across the board with the college and the gastroenterologists.
Thank you. That concludes debate on this topic, and the motion is that our AMA calls on the Commonwealth and state and territory governments to fund sufficient additional training posts required to meet the needs. Oh, I'm sorry, I forgot your right of reply, Georgina.
It's okay. I'd just like to thank everyone that's spoken on this. I think there were some excellent comments there. I'd first like to acknowledge, I think, that this is definitely a first step. There's a need to recognise the need for rural pathways in a number of specialties, not just within GP training. And as has also been said, there's a need to ensure that we have retention of people beyond just the training stage, to actually retaining people in rural areas and supporting them with continued professional development and upskilling they need in order to perform those skills at a high level within a rural community. I also echo the points made about ensuring that rural generalists are providing an equal standard of care, and I think that it's really heartening to see a lot of collaboration between various specialist colleagues and colleges in supporting that and supporting those trainees to be working alongside each other between GP and non-GP specialist trainees. Regarding the issue of quarantining, I think that this is, and I acknowledge this is the contentious part of the motion. I do think, as has been said, that a degree of quarantining is necessary because of the current training environment. I think particularly with relation to working alongside trainees in other colleges, I think having those places quarantined for rural generalist trainees so that they're funded, applied for and so on separately, so that we're not impacting on our non-GP specialist colleagues in their training, and so that we can work alongside each other rather than competing for the same places. I do think we have to be careful that we advocate to enact this in a way that doesn't cause further division between the GP profession, because I acknowledge there's already a lot of splits you know, between different college pathways and various state training organisations. So I think that'll be certainly a case of implementation with how the National Rural Generalist Pathway looks to implement this. And particularly agree with the comments about making sure that these things available are actually aligned to the needs of rural communities. And so I think that was really important. Also the comments made about ensuring that we talk about not just procedural skills, but a broad range of skills. And I know at the Workforce Summit earlier this year, there was a lot of talk about skills and specialists that were in need being in areas such as mental health, you know, and particularly old age mental health in particular as being one example. And I think that traditionally the conversation has been a lot about procedural skills. I think that's a really important part of it, but looking more broadly and saying what does this rural community need, and, you know, making sure that, you know, in looking at the needs of a rural community, that there's a clear pathway for a trainee to get the skills they need to meet those needs, and to also be supported to stay in that community and practice those skills ongoing. So I thank everyone for their responses, and we'll move forward to voting.
Okay, thank you. And so the motion is on the screen that our AMA calls on Commonwealth and state and territory governments to fund sufficient additional training posts required to meet the needs of the NRGP, and agrees that these should be quarantined for the NRGP. Voting is open. We'll bring him on. We'll bring Tim Kelsey's here. Yeah, we may as well do that because these one's going to take longer. Yeah. Yep. And because we started late, we did. So, is anything happening at morning tea? No, just morning tea. So I thought we might as well do it because that's down for 10:30. So if it goes any longer, so we might get results back up if we do that. What will we do? Have him and then have you, and then that's Tim Kelsey, and then we'll break for morning tea at 10:30. Okay. Okay. Yep. Will we have the full time? Yeah, I think we might shorten it, so we'll only go have everyone back at 11 because we've still got a lot of content. Oh, I'm sorry. There we are. The vote is in, and the motion is carried. Thank you. All right, we'll now pause on the policy debates. It's my great pleasure to introduce Mr. Tim Kelsey from the Australian Digital Health Agency. Tim is the Chief Executive of the new Australian Digital Health Agency, and before that, he was the first National Director for Patients and Information in the NHS in England, a role which combined the functions of Chief Technology and Information Officer with responsibility for patient and public participation. Tim was chair of the National Information Board at the same time, and in that capacity led the design of a new national strategy for technology in English healthcare to 2020, which has been adopted by the British government as formal policy. Tim joined the NHS in 2012 after serving as the British government's first executive director of Transparency and Open Data. Tim's a leading advocate of the popular knowledge revolution in our public services, and in 2000 was co-founder of Dr. Foster, a company which pioneered publication of patient outcomes in healthcare. Before Dr. Foster, he was a national newspaper journalist and television reporter. He worked for The Independent and The Sunday Times, as well as Channel 4 and the BBC. He's visiting professor at the Institute for Global Health Innovation at Imperial College London and co-author of Transparency and the Open Society, published by Policy Press and University of Chicago. Welcome, Tim. We're going to sit down.
Thank you very much for that introduction. I'd like to start, if I may, by acknowledging the traditional owners of the land, the Ngunnawal people on which we meet, and acknowledge their elders past and present. I'm here to make the case for technology as a key enabler of high quality and sustainable healthcare. I'm here to say thank you to the Australian Medical Association and clinical colleagues across Australia for their leadership in putting technology to work already for their patients and communities. I am also here to acknowledge the scepticism that many in this room and beyond feel about the benefits that technology brings. And we must be honest, the history of technology in healthcare over the last 10 years, not just in Australia but around the world, has been mixed. But I am also here in the shadow of some of the most pioneering leaders in this country, Mukesh Agarwal, Steve Hambleton, Chris Moy, and of course Michael Gannon, to whom I owe so many personal thanks, to argue that the status quo is not a tolerable option. Australia has one of the best health systems in the world by any measure. It is at the forefront of medical research. It has world-class facilities, and the people so diversely represented in this room that provide care are amongst the most highly skilled and committed professionals anywhere. But the hum and whir of the fax machine in the background of our care services reminds us that there is just so much more we have to do. Paper-based healthcare means that clinicians do not always have the right information at the right time to make the best decisions. And this, again, has been exemplified all too tragically in a recent coronial inquiry in Melbourne into the death of a civil engineer that found a critical medical test had been sent to the wrong fax number. Last August, the Council of Australian Governments unanimously agreed a new digital health strategy. Now, if I was to crystallise this consensus into important, realistic, human outcomes, it would be that, first, by the end of 2018, Australia will be the first country of its size to provide a mobile My Health record to every citizen unless they choose to opt out, putting health literally in the palm of everybody's hands. Second, by 2019, it will have provided every registered clinician with a secure means of communicating digitally with their colleagues without resort to paper or the dreaded fax machine. And third, by 2022, the first regions in Australia will have connected all their care services so that all clinicians in and out of hospital have access to the right information at the right time, seamlessly across all their borders, organisational, administrative and clinical. And I am very grateful to the AMA for its continued advocacy for interoperability of information in Australian healthcare. We called the strategy Safe, Seamless and Secure, evolving health and care to meet the needs of modern Australia. This is not a technology strategy, but a human imperative to improve the health and well-being of every person in this country. There are three overriding principles that you have told us must underpin success in this mission. The first is participation, that this is about empowering people and their care professionals to take more control of health and care. The second is collaboration, that there must be authentic co-design of these services with clinical professionals and the community so that they serve real need. They must always be evidence-based, and we must always listen. And the third is innovation, that we must create platforms for healthcare providers, for industry, for developers, for entrepreneurs, for charities, so that their creativity and businesses can flourish and health outcomes in Australia benefit. I should say now that we are at the start of a journey. The history of technology in healthcare has been mixed. We must manage our expectations. Technology has transformed other industries, airlines and the finance sector, for example, and it will change, is already changing, the experience of healthcare. But this will take time and patience. This is an evolution much more than a revolution. The first of the 7 priorities of the strategy is My Health Record, an online summary of key clinical information which is readily available to a clinician, whether in an emergency or in treatment of a new patient or in the management of a chronic illness, for example, as part of a care team. Access to the most recent diagnostic test results and accurate information on medication and treatment will reduce avoidable admissions into hospital, improve the coordination of care and the number of diagnostic tests that are duplicated. And research here suggests that somewhere between 14 and 20% of diagnostic tests are currently being duplicated. It will also reduce the number of adverse medication events, which run, it's estimated, at around 230,000 each year in Australia. As the Minister said yesterday, My Health Record is about the data that can help save and protect lives of patients and to give the clinicians the opportunity to make earlier and better diagnoses. Today, more than 5.7 million Australians have a My Health Record. Now, in May last year, the Australian government went further on the evidence from 2 opt-out trials and of a long-standing and very successful shared electronic record scheme in the Northern Territory. And they announced in the budget that My Health Record would move to an opt-out registration to accelerate these clinical benefits, meaning that every Australian will have a record by the end of 2018 unless they choose not to do so. We announced last week that the opt-out period will start on July the 16th and run for 3 months. If people want to cancel their record at the end of that period, they can do so at any time, or of course, they can opt back in if they want. The agency, together with governments and primary health networks, clinical and consumer leaders, including the AMA, the College of General Practitioners, the National Aboriginal Community Controlled Health Organisation, the College of Nursing, the Pharmacy Guild, the Pharmaceutical Society of Australia, the Consumers Health Forum, and the Association of Allied Health Professionals, amongst many, many others, have been working with care professionals for the last 6 months, ensuring that they are aware of My Health Record and of the forthcoming opt-out period. This month, every registered health practitioner in the country will receive correspondence from their registration authority, alerting them to the opt-out period and providing them with links to relevant information. It's essential also, of course, that every citizen, every person in Australia is able to make their own decision on participation in My Health Record. And so we are implementing a comprehensive national communication plan to inform the Australian public about it, its security controls and benefits, and their rights to opt out, building on learning from the opt-out trials which involved around 1 million people. Our research tells us that they want to receive information through trusted clinical channels, and especially from their own doctors and nurses, and from related community networks. That information starts on July 16, when people have the facility to opt out, by phone, online, or using paper forms. The AMA and other clinical leaders have been clear with the government for a number of years that the clinical benefits of My Health Record would be accelerated if the system moved to opt out. But they were equally clear that it would only work if it contains high-value clinical content. So I want to reassure you that we have listened very, very carefully to that advice, and that by the end of this year, to reassure you that most public and private hospitals will be connected and uploading, most private and public pathology and community pharmacy providers will be connected and uploading, and most radiology providers as well. This will transform the clinical value of My Health Record. We will soon, in addition, be introducing a series of ongoing design improvements so that, for example, aged care services will start to be connected across the country and information about implanted medical devices will be uploaded. Now, trust is the essence of medicine. Digital services can support confidentiality rather than undermine it. My Health Record operates to the highest cybersecurity standards and is independently audited and tested on that basis by a number of our organisations, including the Australian Signals Directorate. Since the system was launched in 2012, there has been no breach. But let me assure you that real-time vigilance remains our highest priority. People are quite rightly concerned about the security of their clinical information. And beyond our cybersecurity protections, the legislation provides a series of privacy controls, including notifications via SMS and email when a record is accessed by an authorised clinician. It also provides that people can withdraw their consent from documents being uploaded at the point of care, for example, so that sensitive pathology reports can be removed and not uploaded if they choose to. Those documents can also be removed from view after they have been uploaded. Digital health offers many benefits to improving clinical outcomes. Liz Jackson, an obstetrician and gynecologist practicing in Cairns, where the opt-out trials took place, reports that it's been a game changer because everyone has one. When Professor Jackson's patients call the hospital, the midwife looks up their most recent updated pregnancy information on My Health Record and plans what services they need. In a potential emergency, it allows for rapid planning of theatre time and staffing. My Health Record is now the main tool that Liz uses for managing pregnancy records between her rooms, the hospital, her patients and their GPs. My Health Record, she said, is an incredibly valuable tool. It allows 24/7 access to patient records and allows us to work together as a team to deliver high quality and cost-effective medical outcomes. These benefits must, of course, be accessible to all Australians, and that is why we are working so closely with partners in remote and rural Australia and with other communities, including Aboriginal and Torres Strait Islander communities, who may be less familiar with computers or simply not able to access them at all, so that everybody will be supported to access digital health services like My Health Record. I met with an Aboriginal care worker in Melbourne recently who works providing drug and alcohol rehabilitation services to her local community. She worries deeply about the way in which her clients do not always receive coordinated care from the agencies and medical services they encounter because nobody shares information other than on paper, which the clients lose or forget, and then they don't get follow-up and they come back to her rehab services. She herself has a My Health Record and she uses it very regularly. For me, it's great, she said, because I don't have to explain stuff. I try to explain to my people that rather than having to explain their story or forget stuff, this could be a good option. It will be great when we have opt-out. Some people will be apprehensive about My Health Record, and that is their right. It is their right to be sceptical of a move to a digitally empowered health service. But let's reflect on the status quo. I saw a GP in Ballarat right at the start of my work with the agency who showed me a single paper record of a new patient he was treating that was quite literally 3 foot high off the ground. And he was taking it home that night, exasperated and angry, in order to sift through it, in order to identify key items of clinical information. Paper-based healthcare is not just inconvenient and, of course, threatening for people who have to remember their history in the emergency room at the moment they are at their most vulnerable, and how many times have we all heard that? It is also dangerous. My Health Record is only a part of the solution. It is part of a broader strategy to harness the power of the modern information revolution safely and securely to support excellence in Australian healthcare. But it is an important step forward on our collective journey, one of the digital health basics. Artificial intelligence, machine learning, genomics, new technologies will change the world of clinical medicine quickly, but they will only flourish if the digital basics are in place in our health services. If the world is full of faxes, it will not be full of precision medicines. This is a clinical and economic, but above all, human imperative. Thank you again for your support and leadership.
Thank you very much, Tim. That was a compelling address. Well, we'll close this morning's session. Can I ask you to return at 11? We had a slow start this morning because of candidate briefings, so if you could come back early from the gazetted time for morning tea, because we do have a lot of topics still to get through. We'll try and cut down the time it requires for us to vote. That might speed things up. And please leave your devices in the room. Thank you.